Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
As a consultant, I always broke it down into two main areas. One would be really survey-related issues, and then the area I'm most focused on, which is really medical review. These would be everyone's heard of ADRs being additional development requests or additional documentation requests. It's the same thing. So within that, I'm primarily focused on helping home health and hospice agencies in doing their responses to different government entities or reviewers, reviewing records, and then, if needed, appealing any denied claims at various levels of appeal up through and attending administrative law judge hearings on behalf of an agency as their representative. So, and the medical review part, helping agencies understand the different documents, responding to those, and then responding to the results from those and giving guidance. Tied in with that, and this kind of bridges the two areas I mentioned, is that I like to do really education and kind of weave consulting into it, because certainly there's always an opportunity to improve documentation so that in case of any medical review in the future, you don't receive a denial, hopefully. So there's really no way to prevent medical review. There's ways to minimize your chances of undergoing a review, but the reality is, at some point, I think every agency will face some type of review. It just depends on what triggers they have really tripped in relation to it. And you hear the phrase red flags quite a bit. Nobody really defines what a red flag is, but basically, just look for changes in billing patterns in relation to your other agencies in the area. Medicare has multiple review contractors, and they're all reviewing claims with different triggers associated with it. So in regards to the question of what triggers a review, one, it's in one way hidden in that CMS is really hesitant to give out a lot of what triggers reviews. If you look on any Medicare Administrative Contractor or MAC website, being Palmetto Government Benefit Administrators, CGS Administrators, and National Government Services, occasionally they'll post what their current focus for their review is. It may be detailed, such as length of stay, meaning a length of time on home care service. It may be more generic, where they simply say we're reviewing post-pay claims to see if there's a medical review or to see if payment was properly rendered. So in regards to what triggers it, it's just some variance in billing. There are a few other things which may trigger other types of reviews more than the generic review, which is commonly called targeted, probe, and educate. But just within that title, you have the word targeted. So really there was a significant shift in the last 5 years, really, where Medicare, in its biggest sense, decided to invest their review resources in targeting certain issues or certain areas. So therefore, agencies, it used to be that a wide variety of claims would be reviewed and then see if there was a problem. Medicare said, well, that's not really cost effective on their end, so let's target review. The targets are selected based on billing changes that occur in your agency, and that could be anything from length of stay to average reimbursement per episode changing, to utilization of disciplines or services. And there's other types of medical reviewers that can be triggered by things like complaint calls. These go more in the area of waste, fraud, and abuse. These are primarily done by what's called a Unified Program Integrity Contractor. Those can trigger reviews. And those are things like where the beneficiary's Medicare number showed up, or MBI now, but where they showed up under different providers. Medicare has all these different ways to analyze data to figure if there's a higher risk for what's called a risk to the Medicare trust fund. Any of those things can trigger various types of reviews from any types of reviewers. So that's why I say in the biggest sense, it's a billing difference than your peers, your similar home health agencies in your area. But there's other factors that are external, simply being in a high risk area like Chicago or Detroit puts you at a higher risk for medical review, or Southern Florida, just based on historical medical review activity. In relation to what's triggering reviews in the current environment, primarily, in one hand, it hasn't changed for maybe the last 5 years, I think is really utilization of services, especially therapy. Even under the patient-driven groupings model, that was really supposed to reduce the impact of therapy under reimbursement, which understand that medical review in one way chases reimbursement, meaning you have a higher chance of being reviewed if you have more reimbursement associated with a claim or a bunch of claims. So currently what may be triggering it is Medicare is, and they were very specific about looking at changes in therapy utilization between the prior prospective payment system, PPS, to the PDGM model. So therapy utilization is one. Outliers being when you receive additional money due to a high utilization, because again, there's more reimbursement associated with it. These are generally insulin-dependent diabetics, which have historically had a higher chance of undergoing medical review, those claims undergoing medical review. Those tend to be, I think, the biggest issues. And then a secondary one, very close, I think, is really linked to time on service, that recertification, that more than one home health episode, 60 days, really runs a higher risk of review under the environment, because Medicare is supposed to be really addressing an acute care issue, and to go beyond one episode of care, again, 60 days or 2 payment periods, really would be indicating a check to say, why is this person still needing home health services, which should be addressing issues to either restore loss of function in relation to therapy, or provide nursing assessment teaching in relation to what nursing does. Why is that patient still in service at that point? So those areas, I think, are really coming up as probably identified areas for triggering reviews or running a higher risk of reviews. An ADR, by its actual definition, is called an additional development request, because it's really developing the claim to see whether or not it pays. So most commonly, though, people think of it as additional documentation. CMS actually uses both, but the actual definition is additional development request. Of course, we just kind of skip all that and call them ADRs, and that takes care of any difference between a development and a document in relation to that. And then also agencies tend to think that all levels of appeal are also classified as ADRs, but they each have a specific name associated with the level of appeal, which is some of what I do, certainly for Gateway, is assisting them that a first level appeal is called a redetermination under Medicare's process, and a second level appeal is called a reconsideration, and a third level appeal is called a administrative law judge hearing request, and a fourth level appeal would be called a Medicare Appeals Council request for review, or Departmental Appeals Board request for review. People just tend to lump everything together, agencies, and call them all ADRs to simplify things. But really, I think once we, ADR is an ADR, and ADR is the chart that's undergoing medical review, and maybe that's the easiest way to think of it. Once that chart is requested, the response goes back to whoever's requesting it, what Medicare entity or contractor. At that point, really, then the review occurs, and it's done under a hierarchy, a 6-step process. And really, it starts off with what are called technical items first. Is there a valid physician certification? Is the valid plan of care present? Are there orders for all services rendered? Are there actual visit notes that match up what was actually billed on the claim? These types of things are looked at first. Right tied in with that is there a valid physician face-to-face encounter, which meets all the certification requirements? And then once those items are satisfied, it tends to then look at actual what's called medical necessity issues. There was service, skilled, reasonable, and necessary. So you need to get your technical compliance areas in order first, so that in case of a review, once a reviewer looks at it, that those are easy denials and may deny the entire claim. And then certainly in relation to face-to-face encounter, if you have recertified that patient or beneficiary, that actually at that point, any subsequent recertification may be denied simply based on documentation of 2 to 3 months or 6 months earlier. So that record will never actually probably be paid if it undergoes medical review, if your face-to-face encounter is not good. One last item in relation to what they're looking at is, and this really ties into which EMR you use in some regard, is that one of the top denial reasons is in relation to therapy services. Medicare has a regulation which says that at least every 30 days that a therapy reassessment is completed. And this reassessment must objectively measure certain findings. And here's the part which results in many denials, is that must then compare those findings to prior assessment. And if you don't do that, then you will be denied the validity of that therapy service until you complete this therapy reassessment. And that's one of the really differences between EMRs. Some electronic medical record systems basically leave it up to agencies to comply with this. Other ones give you a much better, much better pointing towards that. And in that regards, I think Axxess actually is one of the better ones in relation to pointing the clinician to the correct documentation to help take care of one of the top denial reasons right now. In relation to value-based purchasing, I just have one thought in the way, and that would be anything you can do to help facilitate improving outcomes, of course, is a positive. And ready for this word again? Clarity of your charting is a key, in my opinion, to achieving it. So you know where you started, what you're going to do, tying that into a continuum of care, and doing that will improve your outcomes under value-based purchasing. If you are in one of the 5 states, or if an agency is in one of the 5 review choice demonstration states, that's pretty a neutral review right now, and clarity there, again, speeds up your billing. If you can get that pre-claim review, which is a predominant choice, documented, and you can get it so that the reviewer sees all the components are there so that they will provisionally affirm your claim. If you can get that done quicker because of clarity of content, then you're much better off under your billing process to get it in quicker and maintain your cash flow better. And if you are in a review choice demonstration state and you somehow ended up in an ADR option, again, the clarity of content with the ADR means the reviewer can hopefully find that good work you did and then pay your claims. You'll speed up that billing process as well. It's supposed to be a 5-year demonstration project. It had a few, detours and hiccups along the way. I can't see how it won't go nationwide just to eliminate the pay and chase model of medical review. Of course, it's all falling to palmetto right now, but I can certainly see once we get past this public health emergency issue, and then once we make that next step in the billing issue of the notice of admission, the next major step, along with value-based purchasing, really should be pre-claim reviews, because basically it's the rough equivalent of pre-authorization. It's not the same, obviously. I think it's been well proven for CMS's satisfaction in the states so far. But something that almost every agency will have to deal with at some point is some form of medical review, whether it's from a Medicare administrative contractor, targeted probe and educate review from them, a unified program integrity contractor, a supplemental medical review contractor from Medicare, or the recovery audit contractor, or undergoing a comprehensive error rate testing contractor review, or much more noticeable these days under Medicare Advantage review, some form of medical review will occur. And when that is present, you need an EMR. And those are pretty aggressive medical reviews right now. And they're certainly finding through data sifting and data analysis issues with therapy documentation. So when you generate when you choose your EMR, you want clarity of content from a compliance viewpoint. If you don't have that, you're going to be giving back a lot of money down the road. I'd much rather spend my time doing education than trying to recover lost money for an agency. And therefore, it should be a consideration when you're choosing your EMR. Just real quick aside is that most types of medical review now are done on what's called a post-payment basis. And it's very common for what are called extrapolations of review results to occur. And quickly this can turn agency denials into $1 to $2 to $4 million. So anything you can do to prevent that risk is certainly, I think, a viable action you should take as an agency. Under the medical review environment, it's very difficult for an agency to get out of to survive a $3 to $4 million extrapolation. It's a pretty long struggle to do that. You want to avoid it. And, therefore, prevention is the best cure. Getting the right EMR to point you in the direction so that your compliant charting is good. So, choose your EMR wisely. In relation to a comparison or a contrast, when you look at use of electronic medical records or EMR systems versus paper, and when I started in home care, of course, it was paper, is that EMRs give you a template and they give you a framework. Within that framework, you still need to make that patient specific, and following the physician orders and plan of care, you need to make that so that it really directly addresses what you are doing and the need of the patient. And following those physician orders. Medicare is really specific in this in two places, actually, in the Medicare Benefit Policy Manual, and they have this phrase called longitudinal charting, or it references that. Both applies to nursing and therapy services, where basically they specifically say that simply checking boxes on a form or a template is not valid and is not sufficient to properly display what you did on that visit and communicate what you did. Many EMRs give too many checkbox options, in my opinion, and that really detracts from the clarity of the record. And then in relation to a handwritten document, again, you're really writing exactly what you're doing. Legibility becomes an issue. So, handwritten documents for the most part are not going to cut it anymore. And then the EMR you choose should be for maximum clarity and communication of what you did do on that record without putting too much extraneous content in it. When I get to review an Axxess record, or record generated in Axxess, I should say, to me, it really, if there's one word that comes back, it comes to clarity, in that I am able to find documents easier. These would be whether it's the OASIS assessment or therapy evaluations or visit notes. And then when I go to that document itself, it is extremely readable and legible. Things maybe one wouldn't think about, but the print, the size of the print, just the way the page is physically created in a way, it makes it really readable. And that really assists me in finding out what was done or not done within that record, just to assist me with, generating a review, response, or appeal in that. And then within Axxess itself, there are certain areas, again, looking at the record, which do point towards more compliance. If I can take a brief little bit on that, is again, focusing on the therapy reassessment is one of the top denial reasons right now. That within the reassessment document itself within Axxess, that there is a comparative section clearly listed. Many other electronic medical record systems that I do see do have they basically leave it to a narrative to say, well, what comparison is there to prior assessment? Or they have a checkbox saying this is a comparison to the prior assessment. That anything that points you specifically towards a therapist, towards making that documentation on this visit, these findings are present, how does it compare to the prior assessment? That directly addresses one of the top denial reasons. And if it's not there, it's easy for me to find that it's not there. And if it is there, then it's very helpful and very readable within the electronic medical record. So, in that regard, Axxess is one example of how it guides you to the correct response. Also, the second item is that there are a lot of narrative options. So it's both a combination of checkbox and narrative. The narrative is absolutely crucial in generating compliant documentation because it says what you specifically did on that visit, and how to clarify, so you're not constrained by the checkboxes. There are many tired phrases and checkbox lists we've used in home care since I've been in home care since 1994, actually, that if you only check that box these days, it's not going to be good enough to really get a compliant record. So the narrative is a crucial component. Axxess, I think, has both parts of it. And then the third thing in relation to clarity with Axxess is I really do appreciate that any particular document paginates. And you think, well, that's a minor point again. But if you ever have to undergo medical review, you need to reference specific documents and perhaps pages of documents and parts of a page of a document. And if you have to, sadly, if you have to go to administrative law judge hearing, these are done via telephone it's basically a teleconference these days. And the judge has a listing of the record, but you don't actually match that up to your listings. So you end up referencing a specific document. And if you can reference a page of that document for the judge, you are substantially ahead to be able to say, in other words, the physical therapy evaluation of September 16, 2021, page 5 of 7 contains the comparative findings to the prior assessment. If you're able to make that statement, that's a very positive item that the judge can follow you and any other reviewer can follow you in that record. And if you have to do a written request as well, and I do written requests when I do appeals, then I can reference that page. It's a very useful feature as opposed to trying to reference a piece of a document without pagination associated with it. So when you put those three things together, really, the comparative aspect, just the clarity, it's very readable documentation. It's still absolutely incumbent upon the agency to put the right content in that record, but it's still physically a readable document. I think that really does facilitate any reviewer, because I believe that if reviewers can't really read a document, they'll just put it down as illegible, and then they'll just deny it without giving it its due review. Within the organization of Axxess in the electronic medical record when it's being viewed is pretty straightforward, and it really does help when we're looking for documents. My main assistant, who goes into medical records predominantly for me, and she really appreciates the all aspect of it, to be able to get an overview of just what service was provided to that patient, so that we don't miss things. Also, that when items are created, it's unequivocal what they are. Meaning, if it's a visit note, PT visit note, it says that. If it's a recertification, it says that. Some EMRs tend to be less clear on when you look in the record itself to obtain the documents as for whether what that is, a plan of care, is that a referral document. So even within the EMR itself, finding a particular document or content, I think, is much easier than many EMRs that are out there. I think Axxess is a positive in that regard. So there's other EMRs that use what are called continuation pages. That is terrible, because I've got maybe a 15, 20, or 38-page document. I'm looking through it and it says continued, and then I have to somehow find where that narrative continued somewhere else. Axxess doesn't do that. It puts all the information in each individual section. That is a major plus in being able to convey the information that I'm looking for to another person and find the information as well. So it's really much better organized for describing what is there for communication. So people ask me, and I do say Axxess would be the one I would recommend in relation to compliance.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.